Hello everyone. Thank you for joining us today at this TELUS Health Conference added session webinar. My name is Jason Gallant and I am a strategy manager responsible for market intelligence here at TELUS Health, and I will be your MC for the webinar. So we are delighted that you can join us today for this Q&A session. This is your chance to ask the questions that you had concerning the data and trends that we presented at the conference. We are here to answer them. We hope that you will find those next 45 minutes to be informative. So without any further delay, I'm pleased to introduce our two panelists today that you will recognize from the conference. So first, to recap the retrospective data, will be Sean O'Brien, Principal Transformation Services at TELUS Health, and followed by Corey Cohen, pharmacist and director of the professional services, who will be reviewing the trends in medication management. We thank you both for being with us today to answer the questions, and without further ado, I give the floor to Sean.
Just to let everybody know that we're going to share some of the slides that we shared at the respective conferences, but there's no new data that we're going to be presenting today. We're going to go relatively quickly because we want to have a lively discussion with Q&A. So, but we will be presenting some key slides just to level set the audience and to get some context. So I'm going to talk about our key results, drug type utilization, talk a little bit about specialty drug analysis and how they're driving the cost, and then our book of business rankings will finish off. So you'll see here we are referencing Canada versus the regions that we've presented in, so Quebec, Ontario, and then Atlantic Canada is together, as is the Western provinces. You'll see a few highlighted data points here. So in Ontario had the highest eligible cost per prescription at $81.20. Quebec, on the other hand, much lower at $58.50. But as we discussed at the conferences, Quebec pharmacists will typically submit a 30-day supply even for chronic medications rather than the 90 or 100-day supply. That's more common in other provinces. So because of that, there's less quantity per claim, obviously, and then the cost per claim is lower. But you will notice that their utilization is much higher than the rest, and that makes sense as well because they are actually going to the pharmacy even for chronic conditions, usually typically on a monthly basis because they're only getting a 30-day supply. What's also important to note is in the West, the eligible monthly cost per certificate, much lower than the other provinces. And again, given the provinces within the West that do have pharmacare, it makes sense that from a private plan standpoint, the costs are lower per eligible per certificate. And then we've contrasted the generic utilization rate. So Atlantic Canada leads the way with 68%, has the highest generic penetration rate, where we see Quebec is the lowest, and that's traditionally what we saw across the different regions. So for eligible cost change per prescription, 3.2% growth year over year across Canada, but then when we look across the other provinces, or the other regions, there's 3.9% in the Western provinces, so much higher. But again, as you saw earlier, the cost per prescription, eligible cost per prescription, was much lower anyway in that. So it's not a material difference when it's 3.9% on such a small base. But the other regions are running around 3 to 3.3%. So as you can see, a little bit higher than general inflation or CPI. So it's not just cost increase, but really we're seeing therapeutic mix or change in drug mix, and with more specialty drug utilization, obviously it's having an impact on increasing cost per RX. From a utilization standpoint, we saw about a 1% uptick across Canada, increase in utilization monthly per insured, actually lowest in the West where we saw reducing utilization. And then the other regions were in around 1.6 to 1.9%. You see the average age we're showing by region and by Canada over the years, and not really much of a difference. It's been pretty much flat, so it's not really a contributing factor to any of these numbers, year-over-year statistics that we're showing. In this slide, we're just adding what the both insured and their certificate. So in the gray, you're seeing the cost per certificate, or change in utilization per certificate. So when you combine the two, basically you're going to get at your eligible monthly cost per insured. So in Canada, that's gone up 4.2%. So as we saw, most of that is due to increase in cost per claim, with a lesser impact from increased utilization, which went up 1%. We are seeing in Quebec, though, given relatively high cost per claim increases, but we're also seeing higher utilization. So it leads the country in eligible cost change year over year from 2016 at 5.3%. The next few slides will deal with generic utilization. In this example, plotted are for Ontario, but you'll see the other regions are plotted as well. In 2016 and 2017, virtually no change, but 63% of all claims submitted in Ontario were for a generic product. We do see the highest, about 69% in the Atlantic regions. And then generic utilization is much lower in Quebec. Similarly, we're looking at the multi-source brand utilization. So what this means is a brand drug that was dispensed, but a interchangeable generic equivalent could have been dispensed in that particular province. So that has been reducing year over year, but really remained flat again, 7% from 2016 to 2017 for Ontario. The other regions are marginally decreasing, though, over 2016, as you can see. When we combine percentage of total prescriptions, so percentage of apply, 63% of prescriptions in Canada, in Ontario here, were for generics, as we've shown. But when we look at that from a paid percentage, that 63% of generics is only 24% total cost. So obviously generics much cheaper, higher utilized, but much cheaper, certainly given the regulation in generic drug prices across Canada. But we are seeing 71% is for single source brand drugs, and obviously that includes the majority of the specialty drugs are single source as well. So we will continue to see that going up and up. So what we're showing here is plan design Ontario, based on the number of insureds that fall under a generic substitution plan, and we look at either what we call mandatory or more simple generic substitution. So mandatory would be where the physician, even if the physician does write do not substitute or dispense as written on the prescription, the brand drug will still get dispensed, but the generic, it will only pay up to the generic cost. So we are seeing that 84% of insureds under our Ontario book of business do have one of these forms of generic substitution, and we've seen that increasing over the years, as you can see. When we bring in the number of groups, again, this is Ontario, so it's actually 95% of the groups in Ontario under our book of business do have one of these forms of mandatory generic substitution. So really only 5% of plans do not have either form of this. Typically, we see that that's more larger unionized plans that may have to bargain that into the collective bargaining process. And just to compare Ontario versus Canada, 84% in both Ontario and Canada, so very similar. I'm going to touch a little bit on specialty drugs here rather quickly. So we're seeing, and I showed the overall in Ontario, the 101 eligible cost per certificate. That's gone up from $88 over the 9-year period, which is a 1.5% per annum increase. But when we look at non-specialty drugs over the 9-year period, they've actually gone from $78 to $73. So actually reducing in cost for the more traditional non-specialty type medications. But then we look at the average cost of specialty drugs, it's actually gone up much higher growth rate, 12.5% per year over 9 years. So it was $10 monthly cost per all certificates, eligible certificates, and now it's up to actually $29. So it's almost 3 times in that 9-year period. So we're showing here, as you well know, over the years, specialty drug percentage of cost is increasing, continues to increase. Now we're seeing 27% of costs in Canada are driven from only 1% of claimants. So very high cost drugs, but fewer claimants are contributing to the cost. And if we look at it on a regional basis, we are seeing some differences here. Atlantic Canada, 33%, so much higher. We do know that there are certain genetic predispositions in that region, so some very high cost drugs like Fabry's disease, conditions like that are more common in Atlantic Canada. And conversely, in the pharmacare provinces, BC, Saskatchewan, Manitoba, we are seeing much lower cost percentage of specialty drugs, down to 21%. So I'll just touch on the rankings here. We are seeing that from the top 10 classes, we continue to see the immunomodulator class, so typically rheumatoid arthritis drugs, could be Crohn's drugs. High-cost specialty drugs is still number one, ranked as a percentage total paid, and been about the same amount at 11.7% year over year. We do see some other more chronic conditions here, diabetes, asthma, depression, blood pressure, ulcers in the top 10. We're also seeing this year cancers moved up from 12% or the total rank by amount paid a year ago. Now it's at 7. And the top 10 products we're seeing Remicade again continues to be number one. So Remicade, Humira, Stelara, Enbrel. So 4 of the top 5 are high-cost specialty biologic drugs, and those would have fallen into the immunomodulators or the skin condition class in the prior slide. We are seeing a couple brand drugs, multi-source brand drugs, Nexium and Crestor, continue to be in the top 10. And what's interesting is we're seeing a couple drugs now that for ADHD, so Concerta and Vyvanse. So that was very quick, but I want to give time for Corey to present and also talk through some of your questions. So with that, Jason, I don't know if there's any questions on the chat or.
Yeah, actually we received a question for you, Sean, via the chat. So somebody wanted to know if we were able to, if we had more information on the impact of generic substitution between, mandatory generic substitution and regular generic substitution. So do we know if somebody goes with, if a plan actually has regular generic substitution, if that has a different impact than a plan that has a mandatory generic substitution?
Yeah, and it definitely does. The more stricter mandatory will only dispense will only pay for the brand cost if the patient submits the exception form. So much more of a rigorous process, not simply having the physician write dispense as written. So definitely a lot more savings there. So those 5% of plans should be moving to one of the forms, but if you're one of the plans that are on generic, more of a simple generic substitution, it may be worth looking at in your individual circumstances whether it would make sense to have a look at the other version. Again, both of them will still dispense the brand drug, but the more stricter version will pay the brand drug cost, but it was asking for more evidence actually to see why the person couldn't tolerate the generic or was non-responsive to the generic.
Got it. And we have another question that just came in on the chat. How has the fully allocated cost of a diabetic claimant changed, i.e. all the drugs that a diabetic takes?
I think Corey will actually talk a little bit about some of the advances in diabetic therapy when he presented in the other conferences as well. So certainly you see a lot of comorbidities, so higher drug use, and I'm talking more about type 2 diabetes, which is your lifestyle. So you're often seeing someone on insulin or oral products like metformin or some of the newer products, but you're also seeing them maybe they have maybe they're being treated for cholesterol and cardiovascular disease because those are contributing factors to diabetes. So certainly with type 2 diabetes, you're seeing much more holistic costs, even though we're seeing in those slides diabetes as a standalone category. There would be claimants for sure if it's type 2 that would be on cardiovascular cholesterol type medications as well.
Okay, and maybe one last question before moving on to Corey. And the question goes, I always find the average claims data confusing. Can you please indicate what the average monthly amount claim is per employee, regardless of single or family? This should include DIN cost and utilization. And I believe, Sean, that you have that under certificate, right?
Yeah, so certificate is everything rolled up under, the card holder, let's say. So that is, it's not a per employee cost. It's everybody that contributes to that employee certificate or that employee's plan. So it could be a combination of spouse, dependent, employee, or it could, in some instances, it could be just all spouse, or it could be all dependent. But obviously, the costs are higher if you would have family coverage, because then you're covering more people.
Yeah. So thank you for that. So we would be ready for to pass the floor to Corey. So Corey, the floor is yours.
Okay. Well, thanks, Jason, and I'm just skip through here. And thanks to everybody for taking the time out of your days to join us. And much like Sean, I've kind of handpicked some of the key slides from our conferences back in April, and we'll share those with you. And certainly, of course, the intent or objective today is to give you some time to ask questions. And so very quickly, we'll run through these four topics as we did at the conference. And we'll start off with just kind of where Sean left off. And I think, the message we communicated at the conference was sometimes, we do year-over-year rankings for the top 10, and you don't really see a ton of change year-over-year. But when you kind of expand that view over a longer time horizon, you start to see some more interesting things, just partly because it takes some time for things to materialize and see kind of what trends are happening. So if you, focus kind of at the top of this chart in rheumatoid arthritis and diabetes, those both have been 1 and 2 respectively for some time. But when you look over this 4 years, you'll see that both have increased in terms of their percentage of cost over that time. So, starting out, for example, with diabetes at 8% all the way up to over 9% now in terms of total cost for our book of business. And then moving on down, you have, different things happening, like in depression, where those costs have actually decreased over time, largely due to generic entrants in that space of lowering the cost attributed to those medications. And, Sean touched on cancer, and we'll look at that a little bit more detail in terms of its, continuing rise in our book of business for percentage of costs. And then at the conference, we won't look at it today, but we were kind of tracking hepatitis over time and seeing its, pretty big rise in 2015, and then immediately back down the following year, and that's continuing to decline over time. So jumping into a couple of examples, diabetes, there was a question just raised recently on, kind of what that mix is looking like. And I think, the message here is that there has been an ongoing shift to some of the newer medications. And some examples on this slide include Victoza as an injectable, and then Invokana and Jardiance are what's called new SGLT2 products. And, not only do they help manage, the blood sugars, but they also have some additional benefits, including weight loss, and that's where you're starting to see a lot more patients put on these agents. And we've highlighted here two cases of recent trial data from a cardiovascular standpoint, so things like heart attack and stroke, where there's mounting evidence that these agents either, one, don't contribute to any additional risk, but also in some cases lower the risk of these things. So again, further evidence to support patients being treated with these agents. But you'll see at the top, of course, their cost, their average annual cost per patient is quite a bit different than an older drug like metformin at $81 a year. So what we did is, for all new classes of drugs. We looked at new claimants for during 2017 and looked back all the way back to 2010, and we found that of those new starts, about a third across all the categories, there was no prior evidence of metformin use. And for the majority of patients, there will always be some, of course, which can't tolerate or have contraindications or other risk factors that need to be treated. The majority can be certainly treated with metformin, and the question becomes is how do you kind of ensure that that pathway is being followed. And at the bottom we have some suggested strategies where through a managed formulary you could provide different incentives or core insurances to direct patients to some of those lower cost first line alternatives, and then similarly with step therapy. So like an automated prior author approach where the system will check for prior metformin use before paying for a second or third line agent that might be more costly. So that's kind of what has transpired in the diabetes class. And then cancer was the other one we wanted to highlight quickly today. And I don't think it's a surprise to anybody that there's been a ton of innovation in this space, and these are some of the more notable ones in terms of percentage increases since 2016. And much like diabetes, different patient populations are being added, and Revlimid here in terms of moving from later line therapy up to first line in multiple myeloma, and then Ibrance at the bottom in terms of first line metastatic breast cancer. And these are providing great benefits to patients, but of course that comes at a cost. And you'll see the costs are quite a bit different than the diabetes class here on an annual per patient basis. And then the other thing to consider, of course, is that as long as, for the majority of these, as long as patients are responding, they will be treated until progression, until their disease starts to progress. So the patients do better, but that also means an ongoing cost for a longer period of time. And then to help support kind of the management of that, obviously there's traditional approaches like prior authorization, where you want to ensure that the approved indications are reimbursed as opposed to maybe ones that are still being studied. And also looking at avenues for potentially provincial coverage, and then an ongoing management of that patient. So how do they manage their side effects, adherence, etc. So things like case management could help support ensuring that the dollars spent in these areas are reasonable and appropriate over time. So the next section quickly is legislative updates. We showed this kind of scan of some of the more notable legislative updates and changes at a provincial or national level at the conference. And just in the interest of time today, we'll look very quickly at OHIP+, just as a reminder of what's kind of transpired over the first quarter of this year relative to the first quarter of 2017. So on the left-hand side are the first 3 months of 2017, and then on the right-hand side are the first 3 months of 2018. So the same time period year over year. And the orange bar I'll start with is the one at the top, which represents the number of paid claims. And the message here is that is essentially decreased by half what we've seen so far this year. So it was averaging about 300,000 scripts per month, and that's hovering around about 150,000 per month now since OHIP+ has been introduced. The bars represent the cost, and then the color coding you'll see at the bottom represents the category of drugs under ODB, so GB, general benefit, LU, limited use, and EAP for exceptional access program. And as we communicated at the conferences, there's been a big decline in that bottom bucket in terms of general benefits, as we would expect now that that's kind of being redirected to the province. But there are still some dollars flowing through, and that's primarily patients that are wanting to remain on brand, which ODB does not pay for. They only pay the generic price, and some of those dollars are then flowing through to private plans who as Sean mentioned, there's still a proportion of plans that are paying the brand price, and the most notable categories are oral contraceptives and antidepressants that are driving most of that. The other message here is if you move up, so that kind of shaded purple color above the general benefits is limited use, and then green is EAP. We started to see that, you can kind of see in February, March in particular, that's starting to decline, and that is really due to the slow transition of patients over to the public side and getting LU codes, for example, on prescriptions, and then obviously applying to the ministry for EAP approval. So those are some of the highlights, what we've seen so far in the first 3 months of OHIP+. Biosimilars. So we kind of walked through this at the conference in terms of an update of to the previous year in terms of the ongoing use and increase in use of biosimilars. And largely it remains low, unfortunately, in categories like for Enbrel at the top and then Remicade. But you'll notice kind of a stark difference with Grastofil, which is a product used for low white blood counts in patients undergoing chemotherapy. So we kind of wanted to look at that a little bit further and kind of understand what's happening there and what's some of the driving factors of why that would be higher. And so this was some of the data we showed, and we can kind of start to see when we look at a regional level what's happening behind the scenes. So on the left-hand side is Ontario, and in the blue line is the originator brand, so Neupogen, and at the bottom in green is the biosimilar Grastofil. So Grastofil received its Health Canada approval, or NLC, in spring of 2016, and then kind of slowly trekked along, and then received an ODB listing in late 2016. And you'll see how much that public payer listing has impacted private plan drug use. So these are, of course, private payer claims, and once that was listed by ODB, you see kind of the dramatic rise. The other things we commented on here to keep in mind in terms of some of the other driving factors of the increased use is that Grastofil, given the nature of the product, is used on an acute basis. So they're not our ongoing claimants that we need to worry about switching and kind of an ongoing usage. It's every new patient is a new prescription as they encounter this side effect of chemotherapy. The other thing to consider is a lot of this drug is prescribed out of cancer centers, so there could be greater awareness within cancer centers and different protocols, pre-printed order forms that help drive the use of the biosimilar. In contrast, you look at Quebec on the right, no provincial coverage there on RAMQ. Probably no surprise then, limited to no uptake in Quebec of the biosimilar. So, the message here is just how much the public payer direction has impacted the use of biosimilars on private plans. And then the last section for today is the drug pipeline. So this is the biosimilar pipeline that we presented, and there's a number of biosimilars expected to be launched in the next 3 years. Some are already currently under review with Health Canada, as noted here. I believe one actually recently received approval in the last week or two. But what we wanted to highlight is the dollars that our book of business is currently spending on these agents, and the current biosimilars on the market range in about a cost, a benefit of about 20 to 50% relative to the originator brand. And if we were to assume a fairly low percentage discount on these agents when they come to market, I mean, we're spending over $270 million, and just a 20% reduction in price would be over $50 million. So there's a lot of opportunity with these once they come to market, but keeping in mind some of the different clinical factors, indications that may get approved, and how do we go about encouraging their use in private plans. And then I believe this is the last slide for today, is just a very quick look at the short-term pipeline. So these are some of the categories of drugs that are currently under review with Health Canada now that I guess as part of one of its transparency initiatives is posting all the drugs that are under review. 1/3 of all the reviews that are currently underway are within 3 categories, so cancer, HIV/AIDS, diabetes, so there'll be ongoing approvals in those areas. And then some of the other notable things that are in that list include biologics for migraine, which we're expecting approvals this year, as well as biologics for some blood conditions, hemophilia A, and then another one for plaque psoriasis. So I believe that's a very quick run-through of some of the pertinent or top-level conference material. I think we'll pass it over to Jason and address some questions.
Yeah, so thanks for that recap, and thanks again, Sean, to you as well for sharing your expertise and knowledge. So at this time, we will actually open the floor to our listeners. To submit your question, just a quick reminder that you can use the chat box on the right of the screen, or press 01 on your phone as the lines are currently unmuted. So you have the opportunity of verbally asking your question. We have some questions that came through the chat during your presentation, Corey. So the first one is actually, I think, geared towards Sean. What is the breakdown in terms of number of lives with different copay levels, so 20% copay, 10% copay, no copay. So, Sean, are you able to provide some kind of an idea of that, the breakdown of the number of lives between the different copay levels?
I wouldn't have that off the top of my head, no.
Okay.
We do have that information, so we can certainly follow up.
Yeah. Okay, so we have another question regarding, plan design once again. What percentage of plans have an annual plan maximum or a lifetime maximum? So once again, it's hard to be put on the spot, for this data, but any ideas that comes top of mind, any data that comes top of mind? If not, we can definitely do the research and probably get the information out there.
Yeah, I mean, I don't have the hard numbers, but certainly most plans, at least at the extended health level, will have a lifetime maximum, which would include drugs. It's very, very high typically, so not many people would need it. As far as annual maximums, we don't see a lot of them, but we are seeing, and I think it's more the size of the organization. So certainly smaller organizations are starting to look at ways to still provide a benefit plan, but also have some protection. So looking to put in annual maximums because, the strain on pooling charges is unbearable for them at that size. So it is a strategy. I don't know whether it's the best strategy, but for the smaller employers, it may be the only thing that they can do to continue to offer something, but make sure that their costs are capped at a certain amount.
Okay. Thank you. Another question. Can you confirm what the definitions of percentage RX and percentage claimants are? Sean, Corey, I think those were used in your slides. For example, if we look at depression, it is saying that 15% of all claimants have a claim for a depression drug, and this is 8.8% of all prescriptions paid by TELUS. So is that interpretation right?
Yeah, thanks, Jason. So although we didn't show all that data today, when we presented those top 10 rankings by cost, but also having included parameters for percentage of claimants, that does include any active claimants, be it cardholder, spouse, or dependent, and then percentage of prescriptions would be percentage of all prescriptions that would have been dispensed in the calendar year.
Okay, thank you. Another question for Corey. Is there any indication of how much the hemophilia treatment will cost? Do we know how many people in Canada may be affected?
Great question. I don't have a line of sight in terms of the cost where that may land. I would say, considering it's a biologic, kind of consider in that range, given the existing treatments, just kind of knowing how PMPRB does their thing in terms of setting the maximum price. But in terms of the patients, that's something we would have to look at in more detail in terms of what exposure there and get back to that. Yeah.
Okay. Some questions. Any clarifications around the new drugs that are anticipated in diabetes? So I guess, can you provide some insight as to are they new treatments, or I think you mentioned that some of them were combination treatments as well?
Yeah, sure. I can add a bit more flavor to that. So there are some combinations of existing drugs, and the most notable one is the combinations of a GLP-1, so a product like Victoza in addition to insulin. And one, I believe, was actually approved a few weeks ago, so that is coming. That's already coming. And then the other, the ones under the list, under review currently are other molecules in the same category. So, for example, another SGLT2 or another GLP-1, largely. So no, from what I recall, no new classes of products, but either combinations of existing ones or additional products in existing categories.
Okay, thank you. Another question around specialty drugs. So I used to hear that specialty drugs were 2% of claimants, but 20% of the cost. It was expected to grow 30% by 2020. Now you are showing 1% of claimants for 27% of the cost. where is the cost expected to grow in the next 2 to 5 years?
Yeah, I'll take a shot at that. I don't know exactly what it's going to be, but if you look at what's in the pipeline, drug pipelines for manufacturers, certainly heavily concentrated on specialty drug costs, high-cost drugs to treat previously untreated diseases, more rare disease. So I do see that going up. And again, you got to look at that more as an investment as well. So from an employer standpoint, yes, they're high cost, they're treating the minority of people, but they're very, very effective. So there weren't those types of treatments in the past. So ideally, look at it through the lens of, are you keeping people healthy, productive at work? But for sure, the cost will continue to rise as, the percentage of the pie for traditional medications is shrinking because costs are lowering with generics under the PCPA and things like that. So we will continue to see in 2 to 5 years. I think if you look at the historical growth rate, it's going to be following that pattern. So 2 to 5 years, I wouldn't be surprised to see 35%.
Yeah. And maybe just to add to Sean's response, because I think, Sean, you had some of this in the conference too, is the dollars are probably increasing faster than the claimants, and partly due to those new drugs in categories where there's a very small number of claimants, but the dollars are quite high. And I suspect we'll address maybe this next year is products like Strensiq and Spinraza and Kanuma, which are for life-threatening conditions. And I fully agree with Sean is that previously those patients had nothing, and some of these have pretty high mortality rates. And now there are some options for these patients, but they do come at a couple $100,000 a year for some of these agents. So that's probably why that cost is trending faster than the number of claimants too.
And I think if I can add something, I think that the discrepancy, the 2% versus the 1%, the 2% I think we're talking about high cost claimants, and the 1% we're talking about high cost drugs. So I think that can explain the discrepancy that was identified by a listener there. It depends on if you're talking about actually claimants or drugs, because a high-cost claimant can have claims for many drugs, therefore becoming high cost. But here we're really focusing on specifically high-cost drugs. So it depends on what the data is actually. So going back, another question, going back to diabetes, a follow-up question, the diabetes drugs that you were just talking about, what is the cost of those therapies versus existing ones? So Corey, that one's for you. I would be surprised that you have that kind of insight, but by all means, if you do, go ahead.
Yeah, I think just as maybe a general comment, given the fact that there are either combinations of existing drugs or going into categories that already exist, the anticipation is those dollars would be consistent with what's currently available. I think that's all I could say at this time, but otherwise, the costs are what we've presented today.
Okay, so another question around diabetes. Would blood glucose test strips be captured in the diabetes therapy class?
Actually, I may need Sean to verify that. I don't. Yeah.
It definitely is. So test strips, lancets, syringes, any supplies are also part of that cost. But the majority of the cost is from the actual drugs.
Okay, thank you for that. A question here on a current hot topic. So, would you be willing to comment on what national pharmacare might be given the political initiatives currently underway? You'd be willing to comment on what the national pharmacare might be given the political initiatives currently underway?
Yeah.
So I guess we're kind of watching as everybody currently is the developments around national pharmacare. Of course, there was a report that was issued mid-April that was recommending a single payer approach. So I think right now we're watching the development as they unfold. Corey or Sean, do you have anything to add on that?
No, I mean, I think that's just it. There's not enough information out there that we could really say one way or the other what it's going to look like. I feel we're going to get to some form of national pharmacare. I don't know the timing, and I'm not sure exactly what that's going to look like.
Mm-hmm.
Yeah, I think like Tim Clark presented at the conference, I mean, the definition of pharmacare is the biggest question, right? And, is that when we say a single payer system, is that a single payer for majority of drugs, for a selection of drugs, for those that only have gaps in coverage? So I think a lot of those questions are still unanswered, unfortunately.
Still a lot of variables to figure out. So a question now around rheumatoid arthritis. So as the senior population increases, what impact to cost for rheumatoid arthritis treatments do you see? So once again, we see the senior population increasing. Does that seem to correlate with the impact, does that seem to have any kind of impact on cost for rheumatoid arthritis?
Yeah, I mean, Corey probably can speak a little bit more to this, but aging, I mean, if we're talking osteoarthritis, yes. Rheumatoid arthritis, not necessarily. It's not necessarily increased risk with age, but identification, most likely as you're getting older, it's probably going to be onset in the later years. I don't know whether there's a real direct correlation, but most likely as aging population, we're going to see the majority of these conditions we're going to see more therapy, and then there's probably going to be more drugs coming to market that will diagnose and detect earlier as well. So.
Yeah, and just to build, I was trying to think trying to think about each of the indications. I think you have to consider the different indications that each one of those is approved, because certainly it's well beyond rheumatoid arthritis, but I'm trying to recall, I think I agree with Sean, is that many of these, I mean, they're autoimmune diseases, so they don't have necessarily a quite tight correlation to age, and many of them are actually diagnosed in the 20s to 40s kind of years, and they're not always, as you get older, there's a greater likelihood necessarily for these conditions as there may be for other things like blood pressure, cholesterol, and different things like that. So,
So we are running a bit long. We have time maybe for one more question. So this will be the last one. How effective has the TELUS Health high cost drug markup cap been on curtailing specialty drug costs?
great question. I think what we've started to see, and it's still I think fairly early, and it kind of has been, I guess, different start dates in different provinces. But we have seen some early success from that, and I think in terms of kind of curbing how pharmacies are submitting those costs to us. But it's something we're still kind of ongoingly looking at. But there have been some small gains so far in that. I don't have a dollar percentage or anything to share at this point in time. But I think it's something we could share at a later date, certainly. Yeah.
Okay, thanks, Corey. So this webinar has already come to an end. If you still have some questions, you can actually email them to telushealth@telus.com, and we will take the time to answer your questions. I would like to thank our two panelists today for your participation. Thank you to our listeners as well for submitting questions and comments. As I mentioned earlier, the recording of this call will be available on our Benefits Hub. It will be available probably at the end of this week. So, and also you'll be receiving a satisfaction survey. So we thank you for taking the time to answer it. Your feedback is always of great value for us when we organize these events. So that concludes today's webinar. I hope you all appreciated the session. Thank you for taking the time to attend this session, and we wish you a great day. Thank you.